Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 367 of our pharmacotherapy series, which majors in acid-base disorders. The next case reads, BLS, a 65-year-old man who was transferred from a long-term acute care facility 2 days previously, is disorientated and lethargic. He was doing well until 1 week before admission, when the staff noted that he was somnolent. He progressively became more lethargic and could no longer remember the names of other persons. BLS has a history of alcoholic cirrhosis, type 2 diabetes mellitus, and hypertension. Medications before admission were nadolol 80 mg daily, isosorbide mononitrate 20 mg twice daily, gleburide 10 mg daily, and spironolactone 50 mg twice daily. On admission, BLS was disoriented to person, place, and time and was difficult to arouse. Vital signs include the following. His body temperature is 37 degrees Celsius. His respiratory rate is 16 breaths per minute. He has a heart rate of 70 beats per minute. And his blood pressure is 154 systolic, 92 diastolic. Pause the video and carefully scrutinize the table at the top of this slide listing some of his pertinent laboratory results. On admission, spironolactone was increased to 200 mg daily and lactulose 60 ml orally 4 times daily was started for treatment of hepatic encephalopathy. Within the first 24 hours of lactulose therapy, BLS produced 4 loose, watery stools. However, his mental status worsened to the point of being unresponsive. His blood pressure dropped to 100 systolic 60 diastolic, and his breathing became labored and eventually required mechanical ventilation. At the time of intubation, his laboratory values were as shown in the following table. Pause the video and carefully scrutinize it. Gram stain of peritoneal fluid revealed many WBC and gram-negative rods. The diagnosis of spontaneous bacterial peritonitis with septic shock is made. I would like you to describe BLS's acid-base status on admission and at the current time. An evaluation of BLS's first ABG results using steps 1 and 2 reveals abnormal partial pressure of carbon dioxide and serum bicarbonate values, suggesting the existence of an underlying acid-base abnormality. The direction of change in his partial pressure of carbon dioxide and serum bicarbonate, along with a pH of 7.43, suggests a respiratory alkalosis is the primary disorder. His calculated anion gap of 8 is not increased. Examination of the ranges of expected compensation reveals that these values are indeed consistent with chronic respiratory alkalosis, serum bicarbonate decreased by 0.5 milliequivalents per liter for each 1 mm of mercury drop in partial pressure of carbon dioxide. BLS's history of alcohol-induced liver disease is consistent with the diagnosis of chronic respiratory alkalosis. The second set of ABG reveals severe acidosis. BLS's serum bicarbonate has fallen from 19 to 13 milliequivalents per liter, and his partial pressure of carbon dioxide has increased acutely from 30 to 48 mm of mercury. Because these values have changed in opposite directions, a mixed acid-base abnormality should be suspected. The diagnosis of a mixed metabolic and respiratory acidosis can be confirmed by applying the stepwise approach outlined previously. If the acidosis were purely metabolic in nature, a serum bicarbonate of 13 milliequivalents per liter should result in hyperventilation and a low partial pressure of carbon dioxide. BLS's partial pressure of carbon dioxide of 48 mm Hg is high, which would be consistent with coexistent respiratory acidosis. The anion gap is 19, indicating an Ag metabolic acidosis is present. The excess anion gap, that is anion gap minus 10, is equal to 9, added to BLS's bicarbonate of 13 yields a corrected bicarbonate of 22, which is normal. This suggests no additional metabolic disturbances are present. The next question reads, what are possible causes for the mixed acidosis in BLS? The anion gap should be calculated in all patients with a metabolic acidosis. BLS's calculated anion gap has increased from 8 to 19 milliequivalents per liter, 11 and 22 milliequivalents per liter, respectively, after adjusting for hypoalbuminemia, suggesting that an elevated anion gap acidosis is now present. Septic shock from bacterial peritonitis can produce profound hypotension, which leads to tissue hypoperfusion, generation of lactic acid, and a subsequent elevation in the anion gap. Other causes of elevated anion gap metabolic acidosis can be excluded with additional laboratory data, e.g., serum ketones, glucose, osmolar gap. Although diarrhea and spironolactone should be considered in the differential diagnosis, these are usually associated with hyperchloremic, normal anion gap metabolic acidosis. The coexisting respiratory acidosis is most likely the result of BLS's altered mental status and his diminished respiratory drive. During the next 6 hours, BLS's hepatic encephalopathy, peritonitis, and acid-base disorders are aggressively treated with lactulose, antibiotics, fluids, and mechanical ventilation. His most recent ABG reveals the following: a pH of 7.45, a partial pressure of carbon dioxide of 24 mm of mercury, a arterial oxygen pressure 90 mm of mercury, bicarbonate of 16 milliequivalents per liter. Ventilator settings are assist control mode at 16 breaths per minute, tidal volume 700 milliliters, and inspired oxygen concentration 40%. BLS is noted to be more awake, anxious, and initiating 25 to 30 breaths per minute. So my question to you is, what is the current acid-base status and probable cause? Evaluation of the ABG reveals a pH at the upper limit of normal with significant decreases in both partial pressure of carbon dioxide and serum bicarbonate concentration. This clinical scenario is most consistent with a mixed acute respiratory alkalosis and ongoing metabolic acidosis. The time frame in which BLS's partial pressure of carbon dioxide decreased from 48 to 24 mm of mercury is consistent with acute respiratory alkalosis. BLS's low serum bicarbonate suggests ongoing metabolic acidosis as a result of his septicemia. The metabolic acidosis should improve with time, given adequate antibiotic therapy and supportive measures that maintain blood pressure and increase oxygen delivery to the tissues. The acute respiratory alkalosis in this case is most likely caused by the mechanical ventilator, BLS's anxiety, or sepsis. In the assist control mode, any inspiratory effort by BLS's results in the delivery of a fully assisted breath by the ventilator. BLS's anxiety and resultant tachypnea are resulting in overventilation, producing excessive carbon dioxide elimination and respiratory alkalosis. Appropriate changes in the therapy may include use of an anxiolytic, an analgesic if needed to treat pain, changing the ventilator settings, or probably a combination of these strategies. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 368.